Good morning to all of you. So I'm going to talk to you about how we can potentially treat central sensitization. But before we get started, I would like to first thank the organization committee and congratulate them with a very good way that they actually made this conference work, and because it's very well organized, and I'm not the only one saying that. So I would like to suggest that we give the organization committee a big applause for what they have done. And I think, for all that I know, perhaps the first three people listed on this slide are the ones who have been working the hardest over the last couple of months to make this all possible. So congratulations to all of you. And I'm the one standing on stage, but I'm talking about the work that has been done by our group, the Pain in Motion research group. And so those are the people that make the things happen. And specifically, I want to thank Sanneke. She's here with us today and at this conference, and she was presenting, or she is presenting a poster on her early PhD findings. And she's a very talented researcher, so I bet you will learn and hear much about her in the upcoming years. And also, of course, Enrique Lusch, who will be lecturing later on today, and he's been working with us for a couple of years now, and it's really been fantastic. He's very active, he's a very talented researcher, so I bet he will be one of the key people, especially in Spanish physiotherapy, and he'll have his PhD in no time. So very happy to work with you, Enrique. Thank you. So this is the content of my presentation, and I will be starting off with explaining some stuff about central sensitization, and then we move on how to treat central sensitization, and treating it from the periphery or treating it from top-down principles. So I don't have time to explain all the details about central sensitization, but I just would like to highlight a few key issues of central sensitization. So normally when you develop any kind of injury, like for instance a neck injury, after a while it activates top-down pain inhibitory mechanisms. And this arrow in this slide is pointing towards the periaqueductal gray, but as you've heard from lectures yesterday, that's not the only key center in the brain orchestrating these top-down pain inhibitory mechanisms. There's a dorsolateral prefrontal cortex, which is very important for organizing these top-down pain inhibitory mechanisms, and also the thalamus, of course, is a crucial part which are activating these red connections in the central nervous system, making sure that top-down pain modulatory systems are activating and that they, in a normal, adaptive way, decrease the incoming input from the tissues. However, we know from a large body of research that this mechanism is not functioning properly anymore in many different types of chronic pain, including some patients, but not all, with low back pain, including many patients with whiplash injuries, including patients with fibromyalgia, chronic fatigue syndrome, knee problems, shoulder problems, and I can go on. So it's been shown in many different patients. Another key mechanism involved in central sensitization, which has often been overlooked, but I think this is probably one of the most important mechanisms explaining central sensitization, is long-term potentiation. And there's been a long history of interest, scientific interest in this mechanism, because it's the mechanism also explaining memory and the things that the fact that we're able to learn new things and that we can remember things. And this mechanism is explained on this slide. So this is the basic synapse with the incoming message arriving over here, the action potential arriving over here, and it triggers exocytosis of these neurotransmitters, these chemicals, which will then pass on the message towards the postsynaptic neuron. And as you can see, this normal synapse is changing dramatically only within a couple of days. So as you can see, 1 week later, following repeated stimulation, these same neurons, they change dramatically in a way that the capacity to produce and let go the neurotransmitters increases substantially, and also the capacity of the postsynaptic cells, the postsynaptic neurons, to receive these chemicals increases substantially. So this implies that 1 week later, these identical neurons, they function in a more excited way, in a stronger way. So the same action potential arriving over here will elicit a stronger and a longer lasting response. And that's one of the key mechanisms involved in central sensitization, and it takes place not only in the dorsal horn, but also in the brain, in fact, in the brain circuitry responsible for the feeling of pain. So this is the net results. As you can see on the left part of the slide, that's the normal situation. So if there is some minor injury, overuse injury, for instance, in the patellar tendon, then there might be some incoming information, sensory input. It might be nociceptive, but it shouldn't be nociceptive. And then it will be passed on towards the brain, and the brain responds, and you start to decrease your training habits, for instance, when you're a jogger or a runner. And it goes away, no problem about that. However, this same minor overuse injury in the patellar tendon might cause a totally different response in the central nervous system in patients having central sensitization. As you can see, this same error results in a much larger input towards the brain, and the brain will respond much more stronger as compared to this situation, even though the incoming information, the incoming stimuli arising from the knee is identical in the left and right part of the slide. So that's the mechanism of central sensitization. And there is now an increasing number of studies showing that there is a subgroup in the knee patellar tendon pain patients that actually have increased sensitivity of the central nervous system, so that central sensitization is also involved in at least some of those patients. And these are a number of my friends. So we studied together, studying physiotherapy, and we graduated 16 years ago in Brussels. But once a year, we still go on a weekend, a reunion weekend. No women allowed, so the women and the children are staying at home. And we have great fun, as you can see. And so I'm the one taking the picture. I'm not on there, of course, and you see those are all physiotherapists, but they're totally different also. You can see this one is making jokes all the time, and he's making funny faces. These guys are into drinking, as you can see about the amount of beer which has disappeared from their glass. But this guy is totally different. He thinks of only one thing, you know? He's a womanizer. And at a certain point in time, a beautiful lady walks in, and this does strange things to his brain, because it activates certain brain areas. It activates the putamen, anterior cingulate, the amygdala, and inferior frontal cortex. And you can look it up in the neuroscience literature. This is also a brain circuitry. And it's the intense pleasure circuitry, which is very easily activated in his brain. So, and for brevity reasons, let's call it and there, of course, there's a lot of central sensitization possible in this circuitry also. There might be dramatic changes in his brain circuitry, in his intense pleasure circuitry. So long-term potentiation has happened in that area or that circuitry of his brain. And so, for clarity reasons, we can call it the sex matrix, which is highly activated in his brain. And if you think I'm So if you think I'm making this up, you can contact him. And he actually provided consent to present this to you in this way and to use his picture. So it's actually true. And he will not deny it, you know. So this, of course, is to resemble the changes in the brain, in the pain matrix in chronic pain patients, because, of course, you are aware and have been listening to very nice lectures yesterday about the brain circuitry involved in chronic pain patients. And there is a lot of long-term potentiation in between all those areas, key areas involved in chronic pain experience. And this is the same with my friend, but not in relation to pain. But even when we are just with the guys, there are no women around, he is still thinking of women, and that resembles our chronic pain patients. There is no tissue damage, but then again, they are having a lot of pain, experiencing a lot of pain. So they don't need real nociception to activate this brain circuitry. And this is, of course, part of the mechanism which has been summarized over here. And we've talked about the dysfunctional top-down pain inhibitory action. Raphael nicely explained stuff about cognitive emotional sensitization. And yesterday we heard from Mark Bishop talking about the dysfunctional stress response, and I will get back to that one later on in the presentation. And as you can see, because this, of course, is highlighting key factors involved in explaining chronic whiplash-associated disorders. But as you can see, there are 6 different boxes in this slide, and only one of them is dedicated to peripheral factors. And when you can see it, when you look at the evidence in relating to these factors, in relation to chronic whiplash-associated disorders, we have to say that they are not that important, especially not in the first phase of the treatment. So treating these dysfunctions, these cervical dysfunctions in chronic whiplash patients doesn't change much in these patients when you look at pain and disability level. And it's not only present in whiplash or fibromyalgia patients, it's also present in some patients with shoulder pain. And I've listed 2 references on this slide, but there are an increasing number of studies, I think 8 or 9 studies now available, showing that in different types of shoulder pain, there is evidence for at least an important subgroup who has increased excitability of the central nervous system. So the question is, when you see a new new shoulder pain patient, whether the local factors are dominating the clinical picture of the patient that's sitting in front of you, or whether you should take into account these pain modulatory factors. And this is a sentence that I like from one of those papers which have shown evidence for central sensitization in some patients with shoulder pain. And it highlights the fact that we should at least take into account the possibility that we should do more than just looking at the shoulder joint and the biomechanical and anatomical pathologies which are over there. And the part of this sentence that I like the most is the fact that the red words that I highlighted in this sentence, because it clearly indicates we should look at both factors and not only focusing on the pain mechanism, so we should combine the 2 worlds. Central sensitization is not an epiphenomenon. It's of real clinical importance, as has been shown in studies showing that the amount of hyperexcitability of the central nervous system, it modulates the outcome of physiotherapy treatment. Not only of physiotherapy treatment, it also modulates the outcome of surgical interventions, as has been shown in shoulder pain and thoracic surgery. And this is a nice figure explaining how the way of looking at patients with osteoarthritis has changed over the last couple of years. Because on the left, this is what has been done for ages. And on the right, you see what we are now trying to do. So we don't forget about what is happening in the joint, because in osteoarthritis patients, you can't ignore the fact that there are things going terribly wrong inside the joints. But then again, there are some changes in the central nervous system, also again highlighting the fact that many patients with osteoarthritis, not all of them, but many of them have increased excitability of the central nervous system. So this implies that we should not only treat the joint, but we should treat the joint together with trying to treat the central nervous system. So how do we treat the central nervous system? That's the big question that many of us are trying to answer, and that's why we're searching for ways of decreasing the excitability of the central nervous system. And when you look at the strategies, one can think of two different ways of approaching the excitability of the central nervous system. The first thing is trying to decrease as much the incoming information. So the bottom-up treatment of central sensitization. So trying to decrease this error to make sure that there is no longer any important upcoming information arising from the skin, from the joints, from the muscles, and all other tissues. Because we know from many studies that many patients with musculoskeletal pain, including patients with low back pain, they have myofascial trigger points. And we know from Nijs microdialysis studies that these myofascial trigger points, the tissues in those muscles and the surrounding tissues surrounding the immediate environment of the myofascial trigger points is totally different as compared to normal muscle tissue. And there are a lot of sensitizing substances in and around myofascial trigger points. Substances which increase the excitability of the peripheral nociceptors. So this is, at least theoretically, a possible way that central sensitization is further developed and further sustained by these peripheral pain generators. So this is what's explained, or what we try to explain in this slide, the fact that it's a possible pain generator arising from the tissues. However, there is no evidence up to now, or not enough evidence to say that we should focus our treatment on treating those myofascial trigger points. But I think it's relevant to at least have more studies to look in the option of including this in the treatment of central sensitization pain treatment. Because you do it with, for instance, with hands-on manual therapy. And we know, and that's the fun thing about it, we know that hands-on treatments, they do not only activate or result in local changes, but they also activate central nervous system mechanisms, central nervous system pain modulatory mechanisms. So hands-on treatment does activate, at least in the short term, descending inhibition. Pain inhibition is activated in response to hands-on treatment. And it works by activating two key areas, the rostral ventromedial medulla, over here, the dorsolateral pons, and they apply both serotonin and noradrenaline for exerting these top-down pain inhibitory action, resulting in less upcoming input arising from the peripheral tissues. However, the effects do not last long, a maximum of 40 minutes according to the scientific work done in that area. So if you want to apply hands-on treatment for your patients with central sensitization pain, I think we have to be careful how to present this type of treatment in the treatment of central sensitization patients. And this is what Enrique has nicely written up in this new paper, which is available online in manual therapy. And these are one of the key mechanisms. So in patients with central sensitization pain, try to integrate your hands-on treatment following intensive pain neuroscience education, as nicely explained in the previous lecture by Raphael. And of course, explain not only the local facts, but rather explain to these patients that you're going to use your hands to activate these top-down pain inhibitory action, which is a total different message as compared to saying to your patients, I'm going to cure your muscles or I'm going to cure your tissues. When you highlight the fact that you're going to use it to treat the brain, then of course it relates to the pain neuroscience education content. Another thing is try not to increase pain anticipation, which is in line with what we heard yesterday. And this you can do by not saying to the patient, this might increase pain, So you just ignore that fact and you quit relying on pain report for adapting and adjusting the way that you provide your treatment. So you just rely on, for instance, range of motion or whatever you feel is appropriate. But don't quit doing the technique or decrease the intensity of the technique because the patient feels more pain. You no longer rely on pain report because if there is central sensitization, pain is no longer a reliable messenger. So you should not rely on it for providing the treatment either. So I guess the main message is, yes, there are some arguments to say that we should also integrate these peripheral treatments in the treatment of central sensitization pain, but there is no convincing evidence to support it. So the main thing we can do to actually decrease the hyperexcitability of central sensitization is to try and target the brain. So try and increase top-down pain inhibitory action. So we can try to deactivate the pain matrix, and you can show this combination of slides to your patients to increase their expectations for a positive treatment outcome. And if you're able to do that, then normally the top-down pain facilitatory action, which is displayed over here, this part of the slide is explaining not the pain inhibitory action, but the pain facilitatory action, which is most of the time activated in response to all these forebrain activities, including catastrophic thoughts, including hypervigilance, including depressive thoughts. And it activates pain facilitation rather than pain inhibitory action. So by changing the way patients think about their pain, we hopefully can decrease this pain facilitatory action. So what we're doing in pain neuroscience education is, of course, trying to reconceptualize the meaning of pain, and this should reduce the threat value of pain, which has been shown repeatedly to decrease the amount of pain catastrophizing and the amount of fear that they experience in relation to their pain. And if you are trying to use it in your own patients, we have a number of free tools to support you in providing pain neuroscience education on our website, translated into Spanish, so you shouldn't worry about the language, so we have provided to you these things. Well, of course, there was a lot of research done on the effects of pain neuroscience education. It started off with the work by David Butler and Lorimer Moseley, and there are now some nice trials from Adrian Law coming out. And we have done a series of studies on that one, and probably the most astonishing finding was in this fibromyalgia study, showing that not only the health status improved of the patients in response to only 2 sessions of pain neuroscience education, but there was a small, not a strong, but it was a small activation of the top-down pain inhibitory action in response to pain neuroscience education, which was not seen in the control treatment group. So this was rather astonishing to see that we can educate our patient and that it will change the top-down pain inhibitory action and will facilitate this top-down pain inhibitory action. And this is in line with findings from colleagues from the United States of America showing that cognitive behavioral therapy is actually able to decrease the excitability, the hyperexcitability of the dorsal horn neurons in patients with fibromyalgia. So yes, behavioral treatments, educational treatments can actually decrease the hyperexcitability of the central nervous system. So this is an appropriate slide to show in Spain, I think. So this guy is not really having a lot of pain right now. And he will be having a lot of pain later on, if he survives, that is. But the reason why he is not suffering a lot of pain is because his stress systems are strongly activated. Why? Because you can see why. Because he's been chased by bull. And Mark Bishop talked nicely about these mechanisms yesterday. And of course, in his situation, this acute stress situation, really threatening situation for that guy, it activates these top-down action, this brain activity resulting in a massive adrenaline response in his body, and this will hopefully save his life. But there is also these more prolonged, more long-term stress response system. It's kind of a delayed stress response system, which is very crucial for recovery following the stressors. And this is the HPA axis that Mark talked to you about, and the net result is more cortisol. And cortisol is a very important hormone, and it's not only important to decrease inflammation, but it's also important for pain inhibition, because there are corticosteroid receptors on the dorsal horn neurons. So more cortisol exerts pain inhibitory action also. So normally stress should be a powerful pain inhibitor. So it should decrease pain. And it does in healthy people. But so many patients come to our clinic and tell us, stress increases my pain. It relates to the pain fluctuations that I experience. And that's normal because these stress mechanisms are no longer functioning properly. Not so many patients have a dysfunctional sympathetic response to pain. That's normally a good response also in chronic pain patients, unlike what was taught previously about that. But this part of the stress response system is dysfunctional in many chronic pain patients. This has been shown in rheumatoid arthritis patients. This has been shown in patients with fibromyalgia, chronic whiplash, and we can go on. And this is summarized in this meta-analysis by people from the Netherlands. And if you want to know how to apply this in practice, you can read this nice paper from Mark Bishop, which was published this year in Physical Therapy. Another connection between stress and the central nervous system and chronic pain is observations showing that severe stress reduces two crucial neurotransmitters inside the brain. That's why I'm showing this slide, or this picture again, of these top-down pain inhibitory action, because you need a lot of GABA aminobutyric acid and you need a lot of serotonin to orchestrate these top-down pain inhibitory action. And severe stress reduces the amount of these key inhibitory neurotransmitters inside the central nervous system. So you get less of these chemicals, so you get less capacity to activate pain inhibition in response to severe and long-term stress. So more pain, less inhibition, more excitability of the central nervous system. So it makes sense why so many patients with chronic pain have a dysfunctional stress response and why they experience that more stress increases their pain, because it increases the excitability of the central nervous system. What can we do about it as physiotherapists? Well, there is no magic bullet for treating stress, but there are several strategies that we can try to apply in these patients. So there's so many relaxation techniques. We've heard about mindfulness, meditation, Schultz relaxation, Jacobson relaxation, and not all of these techniques are appropriate for all patients. So in our clinic, we try to look for which kind of treatment is appropriate for which kind of patients, because some of the patients really love mindfulness, but other patients say, yeah, that's too strange for me. I don't like that type of treatment. So they prefer, for instance, Jacobson muscle relaxation techniques. And it doesn't really matter what type of relaxation you apply, because the main thing is that once you get your patient to effectively use such relaxation techniques themselves, then it will change the brain response during the experience of pain. And this has been shown repeatedly in at least these, and there are some other studies out there showing the same thing, that it changes the brain response during pain when they effectively apply the relaxation or stress management technique. So yes, we can help them with the dysfunctional stress response in their central nervous system. And also exercise activates pain inhibitory action. Exercise is a powerful way of activating pain inhibitory action. However, in some patients with chronic pain, but again, not in all patients with chronic pain, we see a dysfunctional response of pain inhibitory action in response to exercise. What you see over here, these are pain thresholds, and as you can see, these are the patients, and they have, no, these are the healthy people on top. in blue, and as you can see, the pain thresholds before the exercises are much higher in the healthy people as compared to the controls. That makes sense. And this is the response to exercise. You see that there is a strong increase in pain thresholds following exercise. Even one bout of exercise activates this. And this is what we see in patients with typical central sensitization pain. So there is no activation of this top-down pain inhibitory action. The pain thresholds stay the same or decreases even further. Does this mean this dysfunctional pain inhibitory response to exercise, the lack of activation of endogenous analgesia, does this mean that we cannot exercise these patients? No, it doesn't mean that, because there are now several studies, and this was the first to start off this line of research, showing that there is an association between the amount of physical activity on the one hand and the amount of brain activity during painful stimuli. So the pain matrix is different in patients with chronic pain having a lot of physical activity in their daily life as compared to patients doing very low levels of physical activity. So the more active chronic pain patients are, the less activity you see in the pain matrix. And this is confirmed now in longitudinal studies. So it's not a matter of whether or not to use exercise therapy for our chronic pain and central sensitization patients, but it's really the question how to exercise these patients. So, and we should do more work to get proper guidelines on how to exercise these patients and how to possibly reactivate endogenous analgesia in response to exercise in these central sensitization patients. So, and we know from the available evidence that we can apply exercise therapy accounting for cognitive emotional factors. I don't have time to explain this all, but we know that we can address these cognitive emotional factors activating these top-down pain facilitatory actions, so we can try to decrease them by applying exercise therapy. Exercise therapy is a good way to decrease catastrophic thinking, to decrease hypervigilance and depressive thoughts. So this is the summary of what we were talking about over the last couple of minutes in the lecture. So central sensitization is often predominant in musculoskeletal pain patients. So when you look at the options for treating central sensitization pain, it's better to focus on deactivating the pain matrix before you want to include bottom-up treatments. The focus should be, of course, activating these top-down pain inhibitory action. The top-down approach is to be preferred, and we can do exercise therapy, pain neuroscience education, and stress management techniques to try and deactivate the hyperexcitability of the central nervous system. Or perhaps there might be another option. And this is perhaps one of the most fascinating papers I have read over the last couple of years. It's from Paul Hodges' groups in Australia. And what he done, he said, well, perhaps we can combine the two approaches. We can do a simultaneous top-down and bottom-up approach for treating central sensitization in chronic low back pain patients. And what he did is he applied TENS treatment. You're all familiar with TENS treatment, but you might not be familiar with direct current stimulation. This is direct current stimulation, transcranial direct current stimulation. So this is really simple when you look at the device to be used, because it's a very cheap device and you might have it still stored on somewhere in the back of your practice of physiotherapy, so don't throw it away, because they might become useful in the future. Because what they did is they combined TENS treatment with direct current stimulation. It was a small scale study because it was a pilot study, but the findings were really astonishing. They combined transcranial direct current stimulation with TENS treatment. So the TENS treatment performed in the lower back, so bottom up, activating the muscles and the skin surrounding the lower back, and it was combined with direct current stimulation. And the results are really astonishing. Sham treatment or the direct current stimulation alone or TENS treatment alone, the results were very poor. But when you looked at the combined treatment, it was much better, and the results were really spectacular. When you look at the reorganization of the somatosensory cortex, and also the measures of central sensitization improved very substantially. So there was less central sensitization following the combined treatment. And what this direct current stimulation technique does, it changes the excitability of brain circuitry. And depending on where you place the electrodes, it can shift the neuronal membrane potential in a direction which increases the excitability or away from the excitability. So, and it potentially, at least theoretically, this type of treatment can decrease the excitability of the pain matrix, and hopefully it can increase the excitability of the top-down pain inhibitory action. But when you look at the results, the effectiveness of this technique in chronic pain patients alone, the results are rather poor with small effect sizes, insufficient evidence, but this type of combined treatment might increase the effectiveness of this technique. So be aware of electrotherapy, so there might become in the future a place for the treatment of chronic pain, again with electrotherapy. So to end this lecture, I want to make a little bit publicity for our Congress, which will be held in March in Brussels in 2015, next year, so that is. And it will be a PhD researchers-focused Congress. We'll have 3 or 4 keynote lectures, but besides that, only PhD researchers will be on stage. So if any of you are doing a PhD in pain science, feel free to submit an abstract. You can still submit until the end of this month, so it closes off 1 November, the abstract submission. And if you, so we'll have a low threshold for allowing people to present. And if you get the chance to present your work, then you will get a free entrance for the Congress. So you can check it out on our website if you like. And of course, if you're not presenting, you're welcome also to attend the Congress. And to finish up, I would like to express my concerns about the way it is sometimes, especially in social media, is put like this, that there are 2 worlds, especially in physiotherapy, the ones applying biomechanics and movement science and the anatomy specialist. And they're saying, okay, this is what we have to look like. And then this is us. We're on the planet. You know, this is a different planet. But anyway, it appears to be 2 planets, and they're combating one another. And sometimes it becomes rather aggressive. And I don't think that's a good way to approach and to improve our profession. So hopefully we can change it in this direction. And that's what Enrique is also doing, trying to combine different views on treating patients and not only saying, okay, there is pain science and there's nothing else, but because there is something else. We should not forget about the muscles and the joints either. And hopefully by combining the 2 worlds, bringing the 2 worlds together, this will facilitate our treatment for our patients. If you want to know more, the next course we will give, 2-day course in Spain, will be in December in Valladolid, and that's all I have for you. Thank you.